Good evening, everyone. Tonight, we are going to listen to a very important webinar. Is good for your FRCS exam, as well as your daily practice as a consultant or senior orthopedic surgeon in the UK. The speaker is Sunil Garg. He's an excellent upper limb surgeon. I know him when he was in Southeast rotation. Now he's upper limb surgeon for over, how long, Sunil?
About 13 years.
13 years. He's a great surgeon, and he's going through the distal biceps rupture. And once this finish, we go into do Zoom quiz, and ask you questions. And these questions, they are timed, so you have to be quick. And I want to say, all of you participate, do not worry, because this is anonymous. So no one knows who is voting and what's your score. So try to vote. This helps you prepare for your exam. You better to be stressed now and be relaxed in your FRCS real exam. Then after the questions, we'll give you the marking, and will Mr. Sunil or myself or Nikki, David, all of us will explain to you, and we answer questions. Then we invite anybody, any one of you, to be in the hot seat Viva. That's like simulating the exam, where we give you a 5 minutes Viva, and we try to be exactly as in the exam of FRCS Viva. So it's good opportunity for you. And from my own experience, I avoided this, especially in front of many people when I did my exam, and I did pay the price, because intelligence and experience doesn't help. Half of the exam is just how to answer, take out of your anxiety, and technique. So I was thinking I would do it on my own. It took me longer. I paid lots of money, and it was stressful. So my advice to you, all of you, ORUK and Orthopaedic Academy, is the shortest, quickest, cheapest, and easiest way to pass FRCS from the first time. Next slide. Of course, it closed at 8:30. So the next hour Viva intensive mock exam, I am a part of it, which is going to be on Saturday, 11th of March. This is a bit long, few hours long. And as you know, many of you, I think you already participated in previous ones, and you know how important it is. And again, I encourage every single one, don't stay behind the scene, in the background. It does help, but not as much as you go forward, raise your hand, and be a candidate, and let them grill you here, not in the exam. And I say again, from my own experience, I did spend 10,000–15,000 pounds probably on the exam. Many of them are useless exam, symposium, 700–800 pounds I paid, spend weeks, and you remember nothing. They say FRCS, this is the only platform I know 100% orientated on you passing the exam from the first time, and exactly the same like FRCS. Thanks.
Well, thank you, Dive, and thanks very much, Orthopedic Research UK and Orthopedic Academy, for this invite. So Dive has already eaten up 3 of my minutes, so we'll try and set this up in 27 minutes. So this is an easy topic if you get it for Viva or as a short case, or in any other setting, to be honest. So this is something which we do quite regularly, distal biceps injury. So the session plan is as follows. So we'll look a little bit into anatomy, epidemiology, the mechanism of injury, how it presents to ED, radiology, treatment, complications, what happens if they come late to you, and then questions, obviously. Okay, so in terms of anatomy, you know, we are dealing with the biceps muscle here, which has got biceps. It's got two heads. One of the origins is from the coracoid process, and the other is from the supraglenoid tubercle. So they both come as a tendon on top of the shoulder joint, and then about sort of 8 to 10 centimeters distal, they form the bunch of the biceps. Now, it's interesting that this tendon was thought to be one big muscle, but actually this concept changed after 2007 when Esme actually proved, and in this category study, he showed that actually these two bundles remain separate actually until they are inserted. So that's an important point to remember. Okay. The nerve supply, we all know, is musculocutaneous, which comes from the lateral cord. The point to remember is it enters about 6 centimeters from the tip of the coracoid process into the coracobrachialis. So when you're doing a latiger procedure and when you are dissecting around the delta pectoral interval, you have to be careful about this insertion of the musculocutaneous. So this is just an extended point if you were to apply for your latiger procedures. Okay. So this is just a slide to show you where the musculocutaneous is entering, and then it continues down into the arm to supply the brachialis, and then that's the nerve which continues to become your lateral antebrachial cutaneous nerve, which is very important for the distal biceps repairs. Okay. So now what's important also to remember is how they insert. So when the biceps comes down in the arm, it will insert as two separate bundles on the radial tuberosity. The short head, it inserts a bit distal, and the long head inserts a bit proximal. They're both on the radial tuberosity. They're on the ulnar aspect. The short head is supposed to be a better flexor of the elbow, and the long head is a better supinator because of the way it is attached. The whole tendon externally rotates by 90 degrees to give you that cam effect. Okay. So that's an important point. So why does the distal biceps rupture? So a couple of theories. The first theory is obviously eccentric loading. So most of the time, the elbow is in supination, 90 degrees of flexion almost. And so and then if you're holding a weight against it, that's eccentric loading on the tendon. And also, if you look at the diagram below, you can see that in the space between the radius and ulna reduces in pronation supination at the level of radial tuberosity. That's where your tendon lies. So repetitive pronation supination can cause attrition. And then finally, you have the vascular theory, where you can see you've got 3 zones of the tendon, and zone 1, which is a relatively hypovascular zone, that's where the avulsion occurs. Most of the tendon injuries will be there. It's quite rare to see injuries in zone 3 in the musculotendinous junction, but they are there. So you know, majority of your patients would be men in their late 40s. I'm yet to see a woman in my experience, but there have been cases reported. Now, this is important. Smokers have 7.5 times higher rate of rupture. It's important legally as well as for you for exam preparation. Anabolic steroids, common cause, people especially who are bodybuilding, high BMI, and as we said, repetitive strain injury might have a role in development of these conditions. So there is a theory that the tendon does not just rupture; it ruptures because it went through tendonitis, tendinopathy, partial rupture, and then finally it gave way. Okay. So this is a common slide which you might be shown in your Viva VOCI, where okay, this is a 45-year-old guy who presents to ED, and this is the arm. This is how it looks like. What do you think? How will you manage? What would you do? So essentially, they come to ED or to the GP after trauma, some kind of trauma. Okay, it doesn't have to be weightlifting. They just could be doing flexion in an awkward position. Last guy who came to me, he was just shutting his car boot, and he ruptured. The other guy, he was playing with his cat. The cat jumped. He tried to grab hold of his cat, and then he ruptured his bicep. So there's various mechanisms by which you can rupture. Okay, but they usually arm goes limp afterwards. They notice weakness in the elbow, which is quite temporary. They can present with bruising, especially if the laceratus fibrosus has ruptured, because that's the one which causes hematoma. Or they might have minimal signs, and that's really important because that's why they're missed. a lot of them are missed. More than 20% are missed in ED, and then they become medical legal, and then that's how they present late. So you have to be aware of this. So how do you examine them when they come to you? Clinically? There are a few tests which are important and you must know. The first test is a hook test. You always perform this test from the lateral aspect, and you get them to flex the elbow to 90 degrees, and you insert the finger, your index finger, from the lateral aspect, and you should be able to hook the tendon under your index finger. Okay, and this is almost 100% sensitive and specific, as reported by Sean O'Driscoll. If this test is done properly, you should be able to get a diagnosis clinically. Reverse Popeye sign. So you can see that the biceps bulk, it moves up. And because you will be using the term Popeye, you must know Popeye was a cartoon character. His biceps was like a ball. So this is the classic Popeye sign is seen in long-headed biceps rupture, and the reverse Popeye in distal biceps. You can see on the picture, which is self-explanatory. So the rule in bicep squeeze test is also something which you could be aware of. Someone wants to ask you. Essentially, you squeeze the biceps and you will notice supination. This is essentially done with the patient sat down and the arm is resting on the lap. And once you squeeze, then they show movement, very much similar to what you see in tender Achilles. Okay, it's quite a sensitive test. Then the elbow crease test. So the bulk of the biceps, it lies in the lower third of the middle and lower third. So the lowermost crease will move up like reverse Popeye. And if that's about 6 centimeters more, so if you measure the distance between the elbow crease and the crease of your distal biceps bulk, that's 6 centimeters or more, that's an indication of your biceps rupture. So do you want to do x-rays? Will be normal, obviously, apart from sometimes you might see an avulsion chip, but you could do an ultrasound scan or an MRI scan. Okay, so MRI is no doubt is the gold standard. Ultrasound might be cost effective, but if you're in doubt, go for an MRI scan. And for those of you who want to quote literature, so this is a very good study which has shown beyond doubt that MRI is much more sensitive than ultrasound scan. So the special view which you might want to remember is called the Fabs view, where you can see there's flexion of the shoulder, abduction of the shoulder, as well as supination, and that's why it's called the Fabs view, supination of the forearm. Again, that gives you a good view to look at the tendon. As you can see, the tendon is quite clearly visible here. In terms of treatment, you can talk about the non-operative and operative treatment, and it's really important that this is where you understand. So there's a lot of literature available to you for deciding what to offer to your patient. Non-operative treatment is not a bad option for people who are low demand. However, if you look at studies and medical evidence, most of the evidence is in favor of operative treatment for patients who are active, who have a manual kind of job, and because most of your patients will be in the late 40s, early 50s, they might, if they're manual laborers, then they might want to choose for operative treatment. And the reasons for that would be that if you left them alone with non-operative treatment, they will lose 50% of sustained supination strength, 40% of supination strength, about 15 to 30% of deflection strength, and 15% of grip strength. Now, there is some evidence that this difference in outcome of the strength and supination and flexion, it gets smaller and smaller as the years go by. And some people argue that after 5 years, the difference is minimal. However, that evidence is not robust. So from the evidence point of view, what we know from the papers, for example, these meta-analysis, that there is a significant difference in the supination and the flexion strength. So that is something. Now obviously, these are the advantages, but the disadvantages of operative treatment would be that there is a risk of complications. And the risk of complication could be up to 25%. We'll come to discuss that in a minute. So you have to weigh that risk and benefit. and each patient will deserve will have their own merit of choice. So when it comes to operative treatment, the decision you have to make and you have to discuss in the Viva and also for your practice is whether you choose a single incision or double incision. Okay, the single incision, as the name says, is one incision, you do everything through that. In a double incision, you use one incision to find your tendon, the second incision to insert it. The basic difference is essentially this, what you see on your screen. So the dotted point is your radial tuberosity, where the tendon attaches. In real life, the anatomical insertion is more like what you see on the right side of your screen, which is the tendon is inserted very much ulnar to the radial tuberosity. When you do a single incision approach, you're doing your repair more anterior, so you might potentially lose some of your cam effect. In practice, that's rarely seen, but so that's why it's important that when you start repairing from your single incision, your forearm has to be absolutely super supinated, so hyper supinated, so that you can get to the most ulnar aspect of your radial tuberosity. Okay. What are the other differences? So the main difference is, so if you think about the strength of supination, despite what we discussed here, because with a double incision you can achieve anatomical fixation in more than 75% cases, and it's argued that from the single incision anterior repair you can only probably achieve maybe 25% anatomical repair. So this is the literature, but in reality I don't think that makes much difference, because the outcomes are similar in terms of gaining the strength. The main difference of the single and the sort of the double incision technique lies in the complication rate. So if you look at this table, this is really good meta-analysis, and this summarizes everything, and I don't think you need to know more than this, to be honest. So if you look at the bottom line, it says total complications. It's about 28% in the single incision and 21% with the double incision. Okay. Now, on the face of it, you might think single incision has much higher rate of complication. But if you look at the complications which the single incision has, most of them are temporary. So about 10% chance of the lateral antebrachial cutaneous nerve. Then you have PIN palsy, then you have radial nerve palsy. So, and all these are temporary. Okay, none of them are permanent. Most of them will recover within 6 months. Whereas if you look at double incision, you have heterotropic ossification, which is not something which is temporary. If it occurs, it stays. Then you have a rate of synostosis. And you also have a rate of neuropraxia with that. So you have to weigh your complications. So in single incision, more nerve injury. In double incision, you have more bony problems such as synostosis and hypertrophic ossification. Okay, now coming to whether you do a single or a double fixation, double incision, you have to look at what tendon fixation techniques are available. And they are endo button, suture anchor, bony tunnel, or interference screws. Some surgeons use a combination of these. So essentially the theory is that when your arm is resting, the pressure on the tendon is about 50 newtons. Okay, so you're not holding a weight or nothing, it's just the weight of the arm. So any technique which can maintain a 50 newton of force, which can withstand 50 newtons of force, should be good enough, really. If you look at the force required to rupture this, it's about 220 newtons or so. So therefore, if you look at endo button, which has 400 newtons of force, which it can withstand, I think that is probably the best, followed by the suture anchor and the bony tunnels. But some surgeons combine endo button with interference screw, increasing their strength, but that's probably not required. So, but you must be aware of these 4 techniques. This is just a very quick animation for you to understand the basic technique and revise. So you essentially, the single incision is given anterior, choice is longitudinal or transverse. I give transverse. You find the tendon, which is not that easy to find as in the animation. It's up in the lower part of the arm. You use your finger dissection to deliver it. And then you debride the end of the tendon a little bit, about maybe a centimeter or less, and then you whip stitch it. There are several ways of whip stitching this, okay, but the commonest is the technique here. And you pass an endo button through it, this system is the Arthrex. I don't use a system. I use a toggle lock system, and in toggle lock, it tensions through the sutures which you're seeing. So now you will pass the endo button through the second hole, and then you flip it, and then you try and pass the tendon. This part of surgery is not the easiest because the tendon does not always go into that the hole which you have created, which is unicortical, by the way. So you can have drill bits of sizes 5 mm, 6, 7, 8 mm. 8 mm is the largest size. You don't want to go more than 8 millimeters, because then you can cause fracture of the radial tuberosity and the proximal radius and create a weakness. But yeah, up to 8 mm you can go in there. You can trim your tendon to fit into the tunnel, and that will be a single incision. I don't do double incision, but double incision is quite an attractive sort of. So post-operatively, this is how your X-rays will look like. I used to, many years ago, give them a brace, but I've stopped using a brace for more than 7-8 years. I just give them a woolen crepe and a poly sling for about 2 weeks, and then after that, I let them use the arm gently, and let them go to gentle physiotherapy, and then they are back to full-time work within sort of 6 weeks. But heavy work is only allowed after sort of 4 to 6 months, including sports. So this is. But if you were treating them non-operatively, then obviously you give them sling for a couple of weeks, and you can let them use the arm as able. So that is a big advantage for people who are laborers, that they don't have to take time off work. And that might sometimes, in my practice, that has been a deciding factor for a lot of laborers, when I tell them, look, you'll not be able to go back to scaffolding for another sort of 3 or 4 months or even longer. They cannot afford that. So that becomes a game changer for them. That's an important point to keep in mind. So complications, we've gone through these in the slide of the meta-analysis, but once again, what's important to know is that if you decide to perform surgery, the surgery is, in my opinion, a little bit time sensitive. If you wait for more than 3 weeks, then you are really almost doubling the risk of complications. Although there are some papers which say that the complication rate does not get affected by the timing of surgery, but the tendon goes up and there's more dissection to do. And also, if you start doing this surgery, you will know that once you give your incision and you open up if you're within the first couple of weeks, your path is almost open up there. You just have to slide your finger down and you'll reach the radial tuberosity, and the dissection becomes very easy. However, if you go after 3 or 4 weeks, that dissection becomes tricky, and you find various things, anatomical sort of structures there which you want to avoid, such as the recurrent artery of the radial artery. So these are the complications essentially. Infection, quite rare. Lateral antebrachial cutaneous nerve, 9%. That's mainly because of overstretching. I've tried to avoid that, but most of the cases, you can see it, avoid it. Still, they will have a patchy numbness for a few weeks, and then it recovers. PIN, 2% rate. The best thing is to make sure that you do not retract too much on the radial aspect. So your hormones on the radial aspect has to be quite gentle. So you have to hold it yourself as the surgeon, and your assistant has to very gently hold it. You have to be extremely close to the bone. The PIN almost touches it and is very, very close on the lateral aspect or the radial aspect. Superficial radial nerve can be stretched through your single incision approach, especially synostosis. We've discussed heterotropic calcification, both seen exclusively in, I shouldn't say exclusively, they're sometimes seen in the single incision, but rare. Re-rupture of repair, I've rarely come across. It's been mentioned in the literature, and once again, a radius fracture is quite rare. It's mentioned in the literature. I've not seen it. This is important. So you must know where your lateral cutaneous nerve of the forearm is, and you do a dissection and try and avoid overstretching. If you do get a neuropraxia of this nerve, you will have sort of numbness in the area, in the blue area, as pointed out on the screen. Don't worry, it will get better. I've never seen this stay longer than this for a few months. Most, if not, will come back within 6 months, whether it's PIN or so. Do not rush for an opinion from your peripheral nerve injury surgeon, but there's nothing wrong if you are really very worried and you know that there could have been more than neuropraxia. So it's important. These are just a few slides to let you understand the anatomy, where the recurrent branch of the radial artery is, quite close to where your drill site would be. So you have to make sure you avoid that. Understand the anatomy, where how the posterior introitious nerve enters the supinator heads, the relationship of this nerve, and also the relationship of the PIN and supination and pronation. So as you can see, when you supinate fully, it moves sort of out of your way if you're going anteriorly. But if you completely pronate, like you will have to if you're doing a double incision, then it gets out everywhere again. Okay, so this is just trying to show you where the nerves would be, because this is something which you don't. So this is the complication of synostosis. And this is seen in the double incision technique, because you go through the supinator and you violate the ulnar periosteum sometimes, and this is a complication of that. This is different than that. This is heterotrophic ossification, and I'm not aware of anything which can prevent this. Some surgeons use indomethacin. Yet the results are similar. The rate, thankfully, is less. The main thing is that you do wash properly when you are drilling, so that you do not leave any bone debris in there. So late presentations, obviously the tendon retracts, and that's where you're worried. My personal cutoff would be an absolute 6 weeks. I would not go in without a allograft if I'm going in after 6 weeks. So if they present, beyond 6 weeks, then your options essentially are that you either partially repair it, which is you repair it to the eponeurosis, or you have an allograft ready. Okay, so you have a tendo-Achilles available. So so it's very similar to chronic ruptures. The commonest technique is using an allograft. You could consider, for theoretical reasons, you must know that there is a latissimus dorsi, so the bipolar transfer available. That's quite an extensive surgery, but the commonest would be a tendo-Achilles allograft. So you essentially isolate your biceps, which will be scarred up in the arm. Whatever length you find, you just explore and keep it ready. Then you take your allograft, you prepare like a whip stitch, do exactly what you would do for a primary repair, put it into your distal radius, and then your other end of the allograft, you tie it to your bicep stump in the arm. And the results are not too bad at all. Okay, finally, partial ruptures. So mechanism is acute traumatic, or mainly wear and tear, repetitive pronation, supination. They present with pain in cubital fossa, with tenderness, weakness. You could consider this as tendonitis. An MRI is extremely useful. Once again, the Fabs view, and that will confirm. If there's a rupture, it usually is the short head which ruptures. If it's 50%, then 50% or more, then you've got to take it off completely and put it back, just like primary repair. If it's less than 50%, then you can consider surgical debridement or analgesia. Injection of PRP is something which has been considered and has been successful. Injection of steroid is a bit iffy, and it's best avoided. We have ended the poll. Okay. So essentially, the first question is about the clinical tests for the diagnosis of distal biceps rupture. The question is, which of the following is not used? So we know hook test is the commonest. We mentioned the squeeze test, so it is used. Popeye sign, it's the reverse Popeye sign, which is used, not the Popeye sign. So I do apologize for tricking you. So Popeye sign is not used. Loss of supination strength is used, and bicep squeeze interval test is used. So this is these kind of questions, you've got a nasty examiner who's asking you these questions, someone, not very good. So so you have to just, see which is the best fit here. Hook test, squeeze, loss of supination, bicep squeeze. So the Popeye is the only dodgy one. So that should be the right answer. Okay. So 26% got that right. The rest of you got it wrong, which is probably my fault, if I'm honest.
No, it's not
Okay.
your fault, Sunil. That means people needed this lecture so much for real life and for the exam. Really helpful. That's
Right.
my
No, that's good. So the second one is now this is the key in deciding your sometimes treatment. Non-operative treatment of distal biceps rupture leads to all of the following except. So we know that they can lose 50% of sustained supination strength. We know that they can lose up to 40% of supination strength. They can lose up to 30% flexion and 15% grip. Loss of 20% supination strength is questionable, and that's the right answer because it is 40% supination strength. So that's why I've given both options so they can compare. And majority of you got it right, so that's well done. About 69% got it right. 30% once again got confused between 40% supination, flexion, and grip strength. Okay, so the flexion. So the point here is the biceps is also called as a supinator longa. So when the arm is 90 degrees flexed, the main or the only supinator will be the biceps brachii. When the arm is completely extended, then it's a supinator muscle which does the supination, and biceps has no or minimal role there. And flexion, once again, a main flexor is essentially the brachialis, the deep and the superficial, and contribution from biceps is less than 50%, and that's why the loss of flexion strength is not as high. Okay, so the next question, which I think 64% of you got right. So regarding the repair for distal biceps rupture, all of the following is true, except, so all of the following, so 4 of the statements are true apart from the final one. One of the reasons why I made it this way is so that you can remember the facts, and so it's easier. So this is suture button 400, 380 suture anchor, bony tunnel, interference screw. Whenever you have these kind of questions with these numbers, you know, an examiner will not take too much effort to put in these numbers. So it usually is right. So that is the right answer, that it does occur. Okay, that's true regarding rupture. Most common complication overall is, we said that lateral cutaneous nerve injury, that is 9%. That's also right. And it is the most common complication with single incision technique. That's also right. PI injury is more common in single incision than 2 incision. That's absolutely right. And that was the reason why, you know, Sean Moray decided to, you know, do this approach. Then last one is, in this question, is the wrong answer. Synostosis and heterotrophic ossification are more common with single incision than 2 incision. No, that's wrong. They're both more common with 2 incision technique and not the single. So that's your answer in this one. So 64% got that right. So those who got other questions wrong, essentially, these 3 questions are the key to understanding your distal biceps injury. So if you know these facts, then you'll sail through. Thank you.
Okay, so next we've got some question and answers. So David, would you mind coming live?
Of course. Sorry, bear with me, just get the questions up. So we've got quite a few questions. So first, Matwali wants to ask, why did you do the hook test from lateral to medial, not from medial to lateral?
Okay, so I'm sorry, David, is these are for me to answer, yeah?
Yes, they're for you to answer, yes. So
you.
these questions that people wanted to...
So, see, because you have the laceratus you've got the epineurosis on the medial aspect. The medial aspect is a bit more blunter, so you will not get the accuracy of the test if you did it from medial to lateral. You can try and hook it from medial to lateral as well, but the accuracy as described by Sean O'Driscoll is only from lateral to medial, because you do not have the disadvantage of laceratus fibrosis there, or the epineurosis there.
Perfect. And on that same line, how often does laceratus fibrosis contaminantly ruptured with a biceps tendon?
So you would see most of the time, in more than 50% cases, laceratus fibrosis is ruptured. The sign of that is ecchymosis. If you see ecchymosis and sort of bruising around the area, that's an indication of laceratus fibrosis rupturing. There's no other clinical test to tell you whether it's gone or not, but that is one of the
May I say
signs.
something? One more thing, like you said, Sunil. If you see distal biceps rupture not retracting too much after a patient like come in 1 week, 2 weeks, 3 weeks, that's good sign. It means lacerate is holding it in place. So you
Correct.
said, "Oh, I'm gonna do operation is gonna be easy," just from experience.
Yeah. And then the next question from Ahmed is, can you please re-explain the elbow crease test?
Okay, sure. So the elbow crease test. So you have an elbow crease and you have the biceps. Am I allowed to share my screen again very quickly?
Yes.
Thank you. So let me show you. Okay, so you can see my screen, yeah?
Mm-hmm.
So if you look at the crease of the elbow, now you look at the bulk of the biceps. You can see this is the distal crease of the bulk of the biceps. Okay. Now, when this tendon ruptures, what will happen? This bulk will move up. If you draw a crease here, like this is your elbow crease, and if you draw a crease there, if this crease, if the distance between this crease and this crease is 6 centimeters or more, that means your biceps has moved up, and that is the elbow crease test. Okay, is that okay? Yeah,
that's very well explained. Yes, thank you. Next one. So when you're doing your approach, would you sacrifice the median cutaneous vein in your anterior approach?
Okay, so now I have to be honest, I used to do this surgery without a tourniquet for a few years, but for the last sort of 2 or 3 years, I've started using a tourniquet because it just saves a little bit of my time. Then I release it towards the end. And I have not needed to sacrifice any veins during my dissection. So I think the key is when you give your incision, you are very careful about your superficial dissection. But I suppose if you have to ligate that, that's not the end of the world at all. You can sacrifice it if it makes your life easy. But you don't always have to do it as long as you're careful. So I use a 15 blade, and then I'll go straight onto my cautery. I'll make a skin flap, both distal and proximal, and then I'll use my Mackindos and I'll go through the layers of the veins. At that point, I'll see my lateral cutaneous nerve as well, and then I'll do the finger dissection to go up and find the tendon.
Brilliant. But then the next last 2 questions, but are very much the same. So Jonathan and Hussein want to know about what papers to quote at the Viva station, should you have to. I think you mentioned that 2016 meta-analysis.
Yeah,
that might be a good one for them to use. Can you remember the name? What's the name of the paper? Sorry.
2016 meta-analysis. I can find out in a minute. But yeah, to be honest with you, if you say that the meta-analysis of 2016 or in a meta-analysis this was said, that is good enough, and because as long as you are quoting the facts, because we are all aware, we all, whenever we examine for FRCS Orth, we know there's so much to understand and to remember, that if you are quoting a paper, we are not expecting you to quote a paper unless absolutely it's a landmark big paper. For example, if you were talking about a trial of subacromial decompression, and then you know that there was a trial done by Bess, or if you're talking about the Profa trial, then these big ones you're supposed to know.
Yeah.
But not every sort of meta-analysis is expected.
Yeah, and the reality is you're going to be the person doing the Viva table is not going to be an upper limb surgeon. So the fact that you have some knowledge of a paper is more than enough that they need.
Absolutely, yeah.
Okay, I think that's it for questions. We'll probably, Lydia will probably say, any volunteers for Vivas is the next bit.
He's